our fourth case is a 53-year-old woman with a remote smoking history who presents with a right middle lobe, poorly differentiated non-small cell lung cancer involving non-bulky small volume mediastinal node disease on both sides, 4R and 4L. No driver mutations, and the PD-L1 is 50%. A surgeon who has guided her workup says he thinks this is all potentially resectable, and he is especially optimistic of a good outcome if she has a good response to neoadjuvant chemoimmunotherapy. You are discussing options in your multidisciplinary tumor board, and the surgeon states that the patient is very excited about the possibility of a pathologic complete response. So for this patient who has stage 3B disease with bilateral 4R and 4L involvement, would you favor preoperative chemo, immunotherapy followed by surgery, non-surgical management with chemoradiation followed by immunotherapy, or perhaps some other approach?
Yeah, so this is tough. I can share our own institution's experience and would love to hear both of yours, but generally for contralateral mediastinal nodal involvement, we are not favoring a surgical approach. To us, that is a case that we would direct towards definitive chemoradiation followed by immunotherapy consolidation.
I completely agree. I think that while yes, chemoimmunotherapy is the new conversation piece in multidisciplinary tumor boards, I think we can't forget first principles, and first principles are contralateral mediastinal lymph node involvement, a contraindication to surgery. So I think this would be a case where I would reinforce that, yes, PD-1 pathway blockade is going to be a component of therapy, but the standard of care here would be definitive chemoradiation followed by durvalumab. And we don't really view chemo IO as conversion therapy. We do a radiographic imaging tends to underestimate degree of pathologic response. So I think for all of those reasons, I would not be enthusiastic about a surgical approach.
I definitely agree. This is the patient that we would send to see our folks in radiation and discuss a curative intent chemoradiation approach. And I think with all the upcoming and developing data in the neoadjuvant space, this is one of my worries is, are we going to start overtreating patients, or you could wonder if undertreating at the same time by trying to downstage them with giving neoadjuvant therapy and making them resectable. Patients with N3 disease and bilateral mediastinal involvement were not included in any of the trials that we've been discussing with Empower 10 or Checkmate 816. So definitely this would not be a patient that I would recommend for surgical resection either.
No, I agree, but I will say that I would have equipoise to a study in that setting, and I think that our outcomes for 3B with chemorads, I think there can be some improvement, and neoadjuvant chemoradiation or neoadjuvant chemoimmunotherapy, the outcomes have been quite impressive. And so I think that a direct randomized trial of neoadjuvant versus adjuvant will be difficult to do. And a randomized study of chemoimmunotherapy for resectable versus chemorads, it's also gonna be very difficult to do. But for a 3B, maybe there will be enough volume to do a trial in that setting. You need to do very specialized centers, because the surgery there, if you're doing a bilateral nodal dissection, it's going to require like a sternothoracotomy to get full bilateral mediastinal node coverage, and it's sort of very tricky. So I think that there's the potential to do a trial in that space, but I think I'll study. It sounds like we're in agreement.
And I think the other part to add here is, no driver mutations. What does that mean? And I think across centers and across the United States, there's particularly with community settings, there's a lot of variability on what testing we are obtaining. So something to consider here too, before giving or committing to chemoradiation followed by a year of immunotherapy was truly complete molecular testing of the tumor done, and should should immunotherapy bispecific continue to be a component here or not, or hold it off.